Okay, we still have people joining, but let's get started. And because I'm going to talk for just a couple minutes about the Texas Epidemic Public Health Institute and what we offer. So the TEPHI, the Texas Epidemic Public Health Institute, is a state of Texas agency. Our mission is keeping Texans safe and economy strong by working with community and businesses to strengthen their capacity and resiliency for when future infectious disease outbreaks occur, which unfortunately we know they will. So we, as I mentioned, are housed within UT Health, specifically the School of Public Health, although we work with other UT components. But we have a wide range of partnerships with government, with nonprofit organizations, professional associations, with businesses, other academic institutions, and then community organizations. We offer a pandemic preparedness and response certificate. This is free for Texas residents. It's asynchronous. You can do it at 3 in the morning if you would like, totally online. And it consists of the 4 courses that are listed there. And then there's a culminating capstone tabletop exercise. We do offer continuing education credits for a variety of different professions. And as I mentioned, free to Texas residents. So you can check it out either at our TEPHI website or there is a QR code right there. We also offer, in addition to this general certificate, specialized mini courses. These are, again, free, offer CE credits and online. They range from 1 to 3 hours. You can see our topics there. So check them out again, QR code or just Google TEPHI. You will find our website and we will have it for you at the end as well. I also want to mention one of our signature events is a yearly Public Health Summit. This year it's going to be September 25th, all day in Houston. However, there's an option to register. Again, it is free. Thank you, Texas Legislature. It is free, and you can register either to be in person or online if you don't happen to be in Houston. I do want to mention that Dr. Wells is going to be one of our panelists, so you get a chance to hear her another time. And then here, again, are some of the things that TEPHI does, but look at the website. You'll find a wealth of information, and all of our information and resources are free to Texas residents. So a little bit of housekeeping. If you need closed captioning, you can click on live transcript. We thought that chat was limited. I'm not quite sure what's happening. But if you want to have questions answered at the end, it would be very helpful if you use the Q&A button to submit them. You're also going to get a survey when you're exiting. That helps us a lot to improve these grand rounds, find topics that are of interest. And just mentioning that we already have our September grand rounds. I got to check the date, September 17th at 3 p.m. Dr. Sonia Swiger from Texas A&M is going to be talking on New World Screwworm. So something else to worry about. So we don't have the registration link open yet, but if you sign up on the TEPHI website just for information, you will be you'll get information about it, or check back in a couple of weeks. And then this webinar is being recorded. It will be mailed out in about a week, and you can look at some of our previous webinars. Gee, we've probably had 2.5 years, 3 years of them on our YouTube channel. So again, there's the website, but go to the main TEPHI website if you don't have time to write that down. Okay, so our speaker today is Dr. Katherine Measles Wells. She has an MPH and is a recently minted DRPH in the midst of all this. She's the Director of Public Health for the city of Lubbock. She has led a major expansion of services and staffing there and has positioned the department as a regional public health leader. She previously was at Dishes, managing communicable disease programs across West Texas. She's the past president of the Texas Association of City and County Health Officials, TECHO, and currently is on the board of the National Association of County and City Health Officials, NACHO, where we both are at their conference. And as I mentioned, she holds a doctorate in public health from the University of North Carolina and her MPH from Texas A&M. So take it away.
Thank you for having me here today, TEPHI. Great to talk about measles, and kind of excited to have talking about measles to kind of across the state of Texas. A lot of the presentations so far have been really national, but hopefully we can, through this, give you guys some guidance on what we've been focusing on in Lubbock, and kind of what's led to now we're really seeing a decrease in measles cases across the state of Texas. If you can go ahead to the first slide, please. I first want to say thank you to all of the public health partners that have been part of this outbreak. We're going through huge changes with public health, with questions about funding, lots of attacks on public health, seeing changes to the CDC. But during this outbreak, since January when this started, all of these groups have come together to do what's right for the community. So I definitely want to say a thank you to everybody. I mean, this is the Department of State Health Services, all of the local public health departments that have had cases or have had to investigate cases, CDC, the Texas Immunization Partnership was a great help. And then also all of the physicians and nurses and staff at our local medical centers and outpatient centers. They were the ones that were truly taking care of those infected children and did amazing job keeping those children safe, and then also making sure that we weren't transmitting measles to other kids in those facilities. Go ahead with the next slide. So just to kind of give an overview of where we are on this measles outbreak. I mean, it started in Texas in Gaines County, but it is spread throughout the Southwest. We have cases in Kansas, Oklahoma, and also in New Mexico. As of yesterday, there was 945 cases in this outbreak, 114 hospitalizations, and then unfortunately 3 fatalities. And those were 2 school-age children who were residents of Gaines County who died in Lubbock, Texas, and then a resident of New Mexico. It's also important to note or remember that measles is circulating with this outbreak, but we're also dealing with significant outbreaks up in Canada with thousands of cases, and then we also have a very large outbreak currently in Chihuahua, Mexico, which is south of El Paso. That's also involved with the same community, and unfortunately in Mexico we've already seen 10 fatalities. So measles is not just a little rash. It is very much impacting communities really in North America. Next slide. So I'll talk a little bit about that first case of measles in the state of Texas and how I was notified about it. So everybody knows that public health always happens on Friday afternoon at 4:30, and that's exactly how this measles outbreak started, or my knowledge of the measles outbreak. I was told by one of my EPIs in our health department that the hospital thought they had a measles case. They were asking for the state laboratory to test that individual. And I didn't think much about it because, every once in a while, the hospital thinks they have a measles case and they want to roll out that occurrence. So, we went through the weekend, waiting for that test result. And then what happened was I was at a meeting with, I'm on the board of our United Way, and I was at a meeting, and one of the women that was at the United Way board meeting told me that there was measles going on down in Gaines County. Gaines County is 70 miles from Lubbock. I put two and two together. I'm like, okay, we had a child in the hospital with measles, and now somebody in the public's telling me that something's going on in a county. I immediately got on the phone with many of my public health partners, starting to raise the alarm about the measles case that we were waiting on a test result, but also saying, hey, I'm starting to hear stories about measles cases circulating in Gaines County. We very quickly got that diagnosis that the child tested positive for measles, and at the same time, a second child showed up in the hospital. And none of these children had any recent travel history. I don't think we'll ever know the source case of what started the measles outbreak in Gaines County. But definitely when public health found out about this, there were definitely a significant amount of measles already circulating in that community. And this map over here is just to kind of show you this area of West Texas. The red square is Gaines County. Their main city is Seminole. So that's where the majority of this outbreak is. And then these lines really show you the travel patterns throughout this area. So a lot of people in Gaines County travel to Hobbs, New Mexico for medical care, for shopping. They also travel down through the Midland, Odessa area, and then they'll also travel up to Lubbock. Lubbock's the only community in this area that actually has a full standalone children's hospital. And that's why we saw the majority of the children coming up to Lubbock for care. Next slide. So our early response to measles, this outbreak grew really fast, or it'd probably been brewing, but our understanding in public health, knowing that measles was going on in the community, started a response very quickly. We established an incident command structure on February 3rd, and that was originally a joint incident command with Lubbock Public Health, the South Plains Public Health District, which is the local health department that covers Gaines County, and then the Department of State Health Services, Region 1. With the start of that incident command structure, we were meeting 2 times a day, trying to get all of the resources set up and building capacity to respond to the outbreak. That incident command structure was very quickly expanded as additional jurisdictions were being impacted, either with a case or with providing medical care to children that were potential cases. So we added Amarillo, Andrews County, staff from Region 910, so that they would all have operational awareness or situational awareness of what was going on in the community. One of our biggest needs early on was providing support to our hospitals. When we were learning, or when measles was first showing up, we were missing people were coming into the ER and the waiting rooms, and we weren't necessarily identifying them as measles right away. So we had lots of exposures. So one important thing was making sure we had immune globulin to provide for infants that had been exposed. We also had to make sure we had standardized guidance for PrEP, or for PEP, and then also standardized patient education, so that all of our physicians were providing the same information across all of these different jurisdictions. We also started provider education. So my lead epi started epi office hours, where 2 days a week she was giving a measles update. and then staying online to do questions and answers for all of the healthcare providers in the region. This was like a really quick call and an easy way to get information out to everybody that needed it, and then also being able to provide detailed information for offices or people that were experiencing their first case. We also had to quickly stand up our surveillance capacity. That included moving staff from other areas of public health to support contact tracing. We also had to stand up a way to quickly share data between all of these different jurisdictions. And then we were also able to increase our wastewater surveillance. Gaines County did not have wastewater surveillance for their municipal water system, and we were able to add wastewater surveillance capabilities to their system. And it's very nice now that we're now seeing no measles in that wastewater system. Next slide. So talk a little bit about the healthcare response. A huge burden of taking care of the individuals that were infected with measles fell to the 2 healthcare facilities in Lubbock. Throughout this outbreak, we had over 80 individuals in our community that were hospitalized for measles. So those are mostly children, children that were dehydrated or were having difficulty breathing. We had children with very, very low oxygen levels that even required air transport into our community to get the treatment. Children on ventilators, children having to have supplemental oxygen, just a lot of illness and a lot of great work to take care of those kids. We also saw hundreds of these cases that came in for visits to outpatient settings. So people coming in for that medical care, and that was a big challenge to the healthcare system. Some of the challenges that we had to deal with were determining vaccination status for both visitors and staff. Early on, we had lots of exposures in our waiting rooms. So it was determining who the patient was in that waiting room, but then it was also trying to figure out who else was there with that patient. I mean, in the ER, you know the name of the patient, but you don't know if it was mom and dad or an aunt or a grandparent or a boyfriend that was there with them. So trying to figure out, if there was an exposure, what the risk was to all of these different, both the patients and the visitors. We had to go back to making sure that, patients were in isolation rooms. The hospitals relied a lot on what they had learned during COVID. One of our hospitals still had some of those COVID rooms operational, or were able to quickly move them into isolation rooms, which was helpful. We also had to do a lot of contact tracing with the patients. And then another challenge was decon or decontamination of the transport vehicles. If a child was in the ambulance and infected with measles, we had to keep that ambulance out of service for 2 hours in order to make sure that the measles virus was no longer in there. And that was a challenge, especially in the rural areas where they don't have as many ambulances to rotate. Next slide. One of the other focuses of the outbreak was making sure that we had immunizations and testing available in our community. MMR vaccine was very widely available, and this is something the federal government stepped in with very quickly. They released MMR vaccine to public health so that we could really vaccinate everybody. So we were able to use the TVFC and ASN vaccines to vaccinate all of those eligible individuals. And then the emergency doses that came to us were really great because they didn't have the same rules. We were able to give the emergency doses to anybody coming into clinics if they were insured. So we didn't have to worry about sending them somewhere else if they were insured, if we couldn't bill their insurance. So that made vaccine very accessible and easy for people to get vaccinated. In order to vaccinate as many people as possible, there was a combination of kind of what our health department was doing and then also what the state was doing. So the Department of State Health Services set up strike teams for the rural areas. So they could go in and they could go into different communities every day and offer vaccines. The Department of State Health Services also did a lot of outreach to schools. So schools that had low vaccination rates, they were able to offer like on-site or an evening vaccine clinic to those communities. At our health department, we did a standing vaccine clinic separate from our regular clinical services. So we had clinic open multiple days a week, including in the evenings and including Saturdays and Sundays, where anybody could walk in and get their MMR vaccine. We weren't offering other vaccines through that clinic, but it was just a very simple way: come in, get your vaccine and leave. Set it up very much like how we did our COVID vaccines during the COVID pandemic. And then another really great partner to get the vaccines into arms was our pharmacies and our pediatricians. So a lot of adults went to the pharmacies to get vaccine if they were unvaccinated. And then our pediatricians, especially the ones in Lubbock, did a great job of calling, children that were out of date or hadn't received that first MMR vaccine and gave them vaccinations. Our estimates for Lubbock, we went back and looked, and we gave, as a community, about 3,000 more doses of MMR vaccine than we did in the same period the previous year. So I definitely think that was a successful campaign of getting children vaccinated. And that doesn't count what happened in the other surrounding communities. For testing, we did a couple of different things. The first one is we sent the AMBUS, so we have a 20-person mobile clinic that is part of our hospital district. They sent that down to Gaines County right away and opened up a testing clinic. And that was just a quick, anybody who had symptoms could get tested. They were able to test lots of people through that. And then they were also able to tell us stories about, or be able to be there on the ground, kind of telling us what they were seeing. And they had seen a car full or a van full of people with pretty obvious measles rashes and symptoms. The Department of State Health Services also opened up testing clinics throughout the region. We had our private providers and hospitals were doing the collection for testing and then sending that out to the laboratories for processing. And then we offered testing at our local health department on a drive-up basis. Another component of this outbreak was around community education. So we can't forget that we have to kind of educate the community about measles, the signs and symptoms of measles, what to do when you're exposed and infected. There was a lot of confusion, or people kind of started, it was kind of funny, they started going back to the COVID rules. They were thinking 6 feet or wearing a mask. And it was, it took some re-education to start talking about the incubation periods and how long you have to stay quarantined if you're exposed or infected. We also did a lot of work around the importance of vaccine, talking about its being safe and effective. We also tried to get information about who was really at risk for measles. It's truly impacts those that are unvaccinated. We also had to do some education to the worried well. Lots of people wanted to come get a measles booster. So really trying to tell them, who needed the measles vaccine, and trying to settle those who were very worried about measles, but they'd been vaccinated, and really trying to explain to them that they were not at risk. Next slide. Another challenge was working with our daycares and schools. One thing that I think was successful that we did at our local health department, even though we didn't have any measles confirmed cases in our community, everything was just happening in our healthcare center, was we started communicating with those schools by sending emails and information to the school nurses and the superintendents. And I think doing that pre-education on, measles in our community, please start trying to identify children in your facility that are unvaccinated, and please try to get them in for vaccines. I think that helped us a lot, especially when we got to the point where we started seeing cases in our schools. The superintendents already knew what to expect around quarantine and isolation. The Department of State Health Services put out new measles guidance, and there's the link to that. We actually had to write that early on when we first started seeing these cases, because we didn't have an updated guidance document. So we put that together with my health department and the Department of State Health Services. Another thing I did was I penned a letter to parents in our community that had children that were unvaccinated. So I wrote a general letter about, the importance of the vaccine, how it was safe and effective, and how there was a true risk of your child contracting measles now if you were unvaccinated. And the schools really helped push that letter out to all of the parents. And I think we saw some success with that. And then our school nurses were awesome in the community. They'd actually go through the vaccination records of their individual schools. We had school nurses call parents individually, send them letters about the vaccine clinics that were available in the community, and really encourage those parents to come get their kids vaccinated. We had saw a lot of success with that individual one-on-one outreach. Next slide. Unfortunately, we did end up having a fairly decent sized outbreak in one of our daycare centers. This outbreak started when an unvaccinated 3-year-old attended daycare while infectious. The child was sick, had some signs and symptoms of measles, but unfortunately was at school for at least one day while infectious. This infected child actually led to an outbreak of 7 additional cases in the facility. And it just shows how contagious measles is. We ended up with 3 infants in the infant class of that daycare. And this is a daycare of about 100, and I think it's about 185 students in the daycare that ranged from 8 weeks old to kindergarten. So unfortunately, we ended up with 3 infants infected with measles because of exposure to this one child. And then we ended up with 4 children who were eligible for the measles vaccine, broke down with measles. 2 of those children had been vaccinated with 1 dose of the vaccine. So they were breakthrough cases. And then 2 of those children had never had a measles vaccine. The daycare challenge, the daycare was especially challenging because we had to make sure that we got outbreak doses and the IgG, or the immune globulin, to all of the exposed infants in that facility, which took a lot of communication with parents and working with the parents to get them access to that immune globulin. We also needed to offer second doses to all the exposed children ages 1 to 5. So, no children really had a second dose in that facility, or very few had had their second dose. So we went ahead and tried to get all of the children a second dose in that facility. We also had a need to create an infant isolation room in that daycare. The daycare served a lot of low-income families that didn't have sick leave or the ability to be able to stay home with their children for 21 days. So we created an isolation room in the back of the daycare with its own entrance, tried to create some negative airflow to really reduce exposure to those infants, and kept the infants at the facility with the parents really understanding that there was some risk. Thankfully, we did not have any of the children break down with measles while they were in that infant isolation room. Next slide. One of the biggest challenges for me was the media around this measles outbreak. And I really, recommend that public health departments, think about how they would handle this if they were to have measles in your community. There might not be as much national media attention, but really understand how to manage your local media and the onslaught of people wanting information. I think this outbreak was particularly challenging because at the time we were seeing such changeover at the federal level. If you go back, when we go back and look at the dates, I was notified about the measles cases the same week as the inauguration. And at that time, CDC, was on they weren't able to communicate with anybody at that time. We had no CDC director. Their communications were blacked out. We were seeing the reorganization and the funding cuts. So it made things very complicated. We also had, this is very much a multi-jurisdictional outbreak. So there was the state health department and other health departments that were all needing to get information out to their communities. And that misinformation machine that we were dealing with of all of these people coming into the community and saying, measles isn't bad, or it's just a rash, and providing all of these stories, they move so much faster than public health. So public health really needs to speed up and try to get as much information out to the media as we can. Next slide. So some of my recommendations around communication and some of the things I learned through working through this outbreak was really to lean into your trusted partners. I relied a lot on NACCHO, the Big Cities Health Coalition, these national organizations to help manage some of the media, and then also help get good information out to the communities. Utilize your hospitals, medical school, medical society, find those doctors that are willing to talk about pro-vaccine, willing to get up in front of the news, have a list of them so you know who can help you. And then really reaching out to all of your, your professional network and established reporters that you know and trust. We ended up setting up a centralized way to manage media requests. So our city marketing took on all of the scheduling for me, and we had all reporters go to them. And it took 2 of them to handle all of the media requests. When you're talking to the media, make sure you lead with compassion, really stick to those talking points, and try to stay out of all of the national debate. People really came in and wanted me to criticize everything going on, nationally and at the state level, and really work to try to keep public health messaging, true public health messaging, and let other people take on those harder conversations about all the politics. Next slide. Finish up with some of the lessons I learned, and then really looking forward to hearing your questions, because I think that's the best way to share this information. But definitely be transparent about the outbreak. Don't try to hide that you have measles in your community. They're going to find out. So make sure you get that information out there first. Make sure you share information with your neighboring jurisdictions, because measles doesn't just stay within county lines or regional lines. It's so important that we let people know what's going on. Make sure you know how you're going to get your testing done at the local level, whether or not your LRN has any capacity to do measles testing, or if you'll be shipping everything to Austin. If you have the ability to do wastewater testing, highly recommend that you talk to either the folks at CDC or at TEPHI about how you could establish or set up wastewater surveillance in your own communities. Um, really make sure that you know where your individuals are with low vaccination rates are, and make sure that you are in contact with those communities. And then biggest one that we learned was really that early communication with schools and daycares made a huge difference with this outbreak, and really helped keep the schools on board when we started to see cases in those facilities. And with that, I'm happy to answer any questions.
There, did not want to unmute me. Thank you so much. What a journey you've been through.
Yeah, I know it's a lot of information. It's just there's so much out there and so many lessons learned.
Yeah. We have a lot of questions, and I've tried to sort of group them, and a lot of them you've touched on already. But
Mhm.
I would say the majority of the questions are about communication. I'll just put some out there.
Yeah.
How did you regain trust? Did it matter who was giving the message, like a religious group versus government? Um, how did you get past all the misinformation that's out there? Um, yeah, questions like that.
Yeah. Yes, 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 and yes. No, it the messenger really does matter. I think one of the things that the Texas Immunization Partnership helped us with was some PSAs, utilizing physicians that worked in Gaines County and had a connection to the Mennonite community in Gaines County. So I think that was one part of the communication. Um, I think the communication from like our pediatricians' offices to parents made a big difference with increasing vaccination rates in Lubbock. Even just sending out text, they did a text message blast, one of our big pediatric offices of, to all of the children that needed the vaccine, and really encourage them to get that vaccine. And then having all of those different, physicians talk on the news with me. We did, multiple press conferences, and I was trying to bring in different individuals to talk about what they were seeing in their practices, and that measles wasn't mild for everybody, and that we needed people to get the vaccine.
Great. A couple of, I think, quick answers. Did you collaborate with the pharmacy school in Lubbock to give out vaccinations? Sorry, I didn't
Yeah,
think.
the pharmacy school is actually up in Amarillo, so we don't have a specific
Oh, okay.
one. We partnered with United grocery stores. We do a lot of back to school vaccines with them. We don't have HEB. We only have one HEB in Lubbock.
Oh,
Most of them
I'm
are
sorry.
United, but their pharmacist is on our board of health, and he was really helpful in making sure vaccines were available in the pharmacies, and then being able to send, especially the adults, to there to go get their vaccine.
And did you have, or are you aware of any people who could not be vaccinated because they were immunocompromised or pregnant? And if so, how you dealt with that?
Yeah, there were some. I think we saw a lot of pregnant women. We had over, I think there was at least 5 women that contracted measles um, while being pregnant. And we'll have some better data and a paper coming out hopefully soon about that. and transmitted it to the babies. Um, I kind of felt like I was talking about COVID again, because you were talking about, staying home. There are people that were immune compromised that did not feel comfortable going to Walmart or to Target or Costco, all of these big box stores where they could have been exposed. I know lots of families, are keeping young babies home. Lots of concerned moms about sending babies to daycare. It is a challenge. And, we talk a lot about people's rights to not get vaccinated, but then there's also this group that's impacted by that group that doesn't get, that chooses not to get vaccinated. It was hard. There was a lot of people very nervous and, frustrated that this outbreak was happening, where they'd always been able to know their children would be safe because measles wasn't circulating.
Yeah. And speaking of vaccines, do you think that this outbreak is going to influence requirements regarding vaccination? And do you think MMR will become mandatory?
Um, I don't have a crystal ball, but I don't see things changing in Texas. We're actually making the exemption process simpler in Texas starting this school year, where parents they no longer have to request the exemption forms from DSHS. They'll be able to print them off on the website. With that, I think it's important that we make vaccines as easy as we possibly can for individuals to get them. I think we need to continue to talk about, how effective they are, how long we've been giving vaccines, especially like MMR. We've been giving it for over 50 years, and it's effective. And it's the reason why we haven't seen measles until now. I mean, this was the first case in our community in 21 years. I think there's also, when I look at people that haven't gotten vaccinated or have chosen not to have their children vaccinated, there's a couple of different buckets there. There's one group of people, which I think is a very small group, that is never going to get vaccinated. I mean, they're, adamant that they're not going to get vaccinated. I think there's another group that hasn't gotten vaccinated either because they haven't had the time. So we have, too many barriers for them to get vaccine, or they are at the thought process, well, I've never seen measles, so why even risk giving my kid a shot? Why make my kid cry, with this injection for something that doesn't exist? And I think for that group, we're seeing them coming and getting vaccinated because now they've seen, what can happen with measles. They've heard about the deaths, they've heard about the hospitalizations, and now that risk is greater than, the little bit of pain from getting the shot.
All right. And then some questions I grouped under how your investigations went. One about wastewater. How did you use those data and how did it impact your investigations?
Um, for Lubbock, we were seeing cases prior to it showing up in the wastewater. And I think that's because the cases weren't living in our community and we just weren't picking it up from people like the wastewater from the hospitals or the medical centers yet. It has helped us kind of declare measles over or us being without a case, because we started seeing it in the wastewater and now it's gone away at the same time as we're not seeing any cases in our community. And then the same things happened in Gaines County. When they got wastewater onboarded, they were seeing lots of cases. Everything was testing positive, and now they're going back to negative tests. But I do think it's a good way to, really identify if you have measles in your community. And we'll continue to do the wastewater testing and be looking for that. And we increased the amount of testing we're doing. So originally, we had only been doing one sample a week that we started in COVID. And now we're sampling from both wastewater treatment plants and are using a different sampling technique.
How about the cases that were the cases that were identified mainly through contact tracing or epi methods, or were they just sporadic and showed up?
A mix. A lot of the cases were linked to a family when one child tested positive for measles, and then you would see it spread through that rest of that community or the rest of that family if the family was unvaccinated. So a lot of the epi work was about isolation and quarantine, of that family to stop that exposure. And then we had to do a lot of epi investigations within, the healthcare exposures. And we actually identified children that, were in the ER at the same time as a measles case. That child was unvaccinated. And then the child broke down with measles within the, 21 days after exposure. So that also helped us stop some of the transmission. It did get to be very difficult to be calling and getting all of those epi investigations done, especially when more so, I think, with the region and Gaines County had a harder time contacting some of those families and being able to provide all of that information to them. It's a different group of individuals in Lubbock. And I think we were able to, for the most part, complete those epi investigations.
And a couple more wastewater questions. I'm only smiling because I could answer these. How many
I might
cases?
have to have you help
Well,
me.
no, one of them I could answer, one I don't think anyone knows the answer to. How many cases have to be in a community in order for it to be measurable in wastewater?
I don't know. Do you know this one?
No, I don't think we
Okay.
do know. Now, I know that in Houston, we've picked up one or two cases, but we just don't really know. And there's a lot of variables about how much, first of all, how often sampling is, how long it takes to get the sample to the lab, what the environmental conditions are, like maybe virus. I mean, you're not measuring viable virus, but the RNA segments that you're detecting by PCR, maybe they disintegrate faster in our 105-degree heat. How much rainfall there's been to dilute it, how many people are in catchment areas. And I don't know about your two in Lubbock, but in Houston, we have some smaller ones and some bigger ones. So basically, I don't think we know. The other question was, does every county in Texas have wastewater testing?
No.
Yeah, I'll let you take that.
Yeah, no, not everybody does. We're here at the NACCHO conference, and wastewater has been a huge, everybody's been very interested in conducting wastewater. And I just highly recommend that every, local health department at least be sampling something. There's a couple of different systems that would allow you to get that wastewater testing done. And I think it's a great surveillance tool, and they keep adding additional diseases that they're able to detect. So, early on it was kind of just COVID, but then we're getting, more and more information as this technology develops. So it's
Yeah.
really awesome, tool for local public health departments.
Let me see how much time I have. Okay, there's another question that's sort of specific, and you can decide whether you want to answer it, or I will get the person's email and you can talk directly about IgG, about the logistics of it, ordering it, setting it up, how you're giving it out.
Yeah.
Besides
I mean, I can
IV.
give kind of a big overview, and then I'm happy to talk to that person
Okay.
offline. The state was able to provide us some IgG, so we kept that at the health department to be able to get to providers quickly if it was needed. Our children's hospital, well, actually, both of our hospitals were great in setting up clinics to be able to provide the IgG and the IVG. They would bring those patients that were exposed back in, like to the ER, so the parents could come, in the evening, and they would administer that. So that was very, very helpful. So that's what the Children's Hospital did, and then our public hospital set up the bus that we used during COVID for infusions. They set that up and were able to administer that. We also purchased the hospitals were also able to purchase from their suppliers. But if they were getting the state supplied vaccine, the hospital was doing, I know the Children's Hospital was doing that at no cost. If we were giving the IV, if we were giving them the product, the hospital was not charging the patient if they were unfunded.
Did you employ Medical Reserve Corps or EPI aid from CDC to help with your investigations?
Couple of different things that helped us with the investigations. We didn't receive any funding to support the measles outbreak directly, but the state did provide us some contracted contact tracers that were able to work within our health department to help with some of that workload. The CDC came in with an EPI aid. For our health department, they didn't provide any contact tracing assistance. The EPI aid was very much focused on exposures in medical facilities and how to mitigate those, how to work with the schools, and then some specific assistance with some complicated exposure cases, trying to determine if it's a true exposure and what that public health response should be.
Was quarantine and isolation mandatory, required by the health department, or just you made the recommendation and whatever happened, happened?
We said it was mandatory, but we did not issue any public health orders. There was no way to, put a police officer or something outside the house. We did communicate with daycares and the school system if that child should have been isolated or, needed to be at home. And we were, I thought it was more important to be telling the schools exactly who those people are, so that those children couldn't come into the school.
Okay. With cases occurring in the US and Mexico, was there any collaboration between the two countries?
I know there's collaboration at the state level. And that's one gap. Like, I never ended up talking to the public health workers like in Lee County, New Mexico. That was done more at the state level. And that was a challenge with this outbreak because those cases definitely spread from Gaines County to Lee County. We know that that community goes there for shopping, but we did not have a lot of situational awareness. And I actually, found out that there was cases in New Mexico, like through the news. I didn't know that beforehand.
What about in the country of Mexico?
Country of Mexico, I think that's more of the binational groups. The slides that I showed you with the maps, those are actually from the Yale School of Public Health, and they're doing an excellent job tracking that whole outbreak, and have a great slide deck that they put out once a week. Yeah, not once a year.
If you had some public health research funding in Gaines County to improve vaccination rates, what would you put it towards?
I think there's a lot of research that we could do in Gaines County. I think we could really do some work on how to reach, these religious, more isolated communities. We definitely, if there was more money to have responded to this outbreak, I think having community health workers or training some of the women in that community about the importance of vaccination would have gone a long way. I think it'd be great to have some curriculum to train women in that community. They do make a lot of the healthcare decisions. Um, and I think some of them felt comfortable getting children vaccinated, but there was also stigma with going to like a state-run clinic to get that vaccine. And I think if we could have, it'd be great to find out if like sending people into the home, with vaccine, with a cooler of vaccine to give vaccine would have been, we would have seen more uptake. Um, I I would like to see some research and some people go in and like really look at what happened in that community. I think there could be a lot of lessons learned. So if someone
And
wants to give us money, well,
yeah. One last one, I know you've talked a lot about communication and how important relationships with the community are, but anything you want to add to that, lessons learned in terms of health department to community relationships
yeah.
in this area?
Yeah, I mean, I think there was a gap there. That, the Mennonite community that moved to Gaines County, and I don't live in Gaines County, I'm seeing this as an outsider, moved into Texas to kind of be in a state that has less government interference. That community really believes in homeschooling. Like they have, they're not certified like religious schools. They really function like more like they function under the homeschool laws, but there might be 100 children gathering for education, and they're able to do that in Texas, and they don't really want to be bothered by government. But I think as public health to serve everybody, and I think you need to understand who those groups are in your community, and have those connections with them, so that there is a crisis, you do have some people that can get that messaging out to you or that are willing to talk to you.
I lied. One other quick question.
Okay.
There's a question about whether older adults, 65 and older, were exposed and then became cases. So we assume that those vaccinated, those born before 1957 were exposed because every child got measles
Yeah.
basically. So some quick math, those folks would be 68 now. The data that Dish has released just showed 21 and older. Do you know, were there cases? I mean, the question is, does your, immunity wane?
Yeah. Now,
Although natural infection versus vaccination might be different too.
when you look at that epi curve, by decade, it is like, I think I could probably say 95% of the people were under the age of 40. There are very few cases of anybody older. And the ones that were older got a huge dose of measles, like taking care of a 2-year-old that was, highly infectious with measles. We saw some breakthrough, but
Yeah, so they had been vaccinated or were old enough to have had natural infection.
but
Okay.
this is definitely an outbreak of younger individuals.
Right. All right, we are out of time. I know people have a lot of questions. I'm sorry we didn't get to all of them. But thank you so much for updating us on what happened here. A lot of kudos in the chat if you're not looking at it. And we appreciate the lessons learned too for
Well,
when this happens again.
thank you all. And, if you're in a local health department and end up with, a case, please reach out to one of the health departments that's been dealing with this. We want to get Texas through this, and, we need that quick local response.
All right, thank you, everybody. And we will see you on September 17th to talk about a completely different subject, New World screwworm. That is hard to say 3 times fast. Have a great rest of your day.
Thank you.